can make it full screen at some point.
Yeah, I will. Okay, tēnā koutou katoa, everyone. Welcome to this week's bioethics seminar. I'm Josephine Johnson. I am an associate professor here at the Otago Bioethics Centre, and with our administrator Angela, I manage these seminars. The seminars run every Monday from 1 to 2 p.m. New Zealand time, and we have a series of local, national and international speakers addressing a variety of topics in bioethics. And as we are having today, sometimes the speaker is in person here at the Bioethics Centre, sometimes on Zoom, and we always have audience members on Zoom. So really you can join our seminars from anywhere. And if you want to be added to the list, just email Angela at bioethics@otago.ac.nz. Before I ask my colleague Tanya to introduce today's speaker, I just want to remind everyone that for people on Zoom, please keep yourself muted. I will also mute this room while the speaker is giving his presentation. The seminar will run for an hour, so until 2 o'clock at local time. And questions and discussion are an important part, so we will have lots of time left for that as part of this seminar. If you are on Zoom and have questions for our speaker, you're more than welcome to pop them into the chat. You can do that anytime and we'll just pull them up during the Q&A session, or you can use the raise hand function and we will see that and call on you to unmute yourself and ask a question. And if you're in the seminar room, just raise your hand and I will call on you. And then we'll just finish a couple minutes before 2 and I'll give a quick preview of next week's seminar. But now I just want to hand it over to Tanya to introduce our speaker. Thank you.
Kia ora koutou. My name is Tanya, one of the lecturers at the Bioethics Centre. And it's my privilege to introduce Matt to you all today. We were recently introduced to each other by Ross Upshur, a colleague we've both worked with or are still working with. So Dr. Mercuri is an associate professor in the Department of Medicine at McMaster University, where he also holds appointments in the Department of Philosophy and the Institute on Ethics and Policy for Innovation. He completed 2 PhDs, so PhD in Health Research Methods in the Department of Clinical Epidemiology and Biostatistics at McMaster, and he did a postdoctoral fellowship in the Department of Medicine at Columbia University, and then a PhD in History and Philosophy of Science and Technology at the University of Toronto, and this is where he worked with Ross Upshur. His research focuses primarily on methodological and philosophical issues related to how we determine effectiveness of interventions and how such information is used to support practice and policy decisions. Matt, the floor is yours. Looking forward to your talk today.
Thank you very much, and thank you for inviting me. I really wish I was there in person, hopefully soon on one of my many visits to your country. I tried to get down there many times in my life, and now I seem to be there all the time. With my wife has recently started working in Auckland. I'm just going to share my screen here. Okay, so for some reason it's not allowing me to do so. I apologize. New computer, and it might kick me out for a second. Let me just.
I think Matt's just logging back in. He should be able to share his screen, no problem. So according to our settings, so let's just see him come back on.
Okay, so I'm back. Now let's see if it'll actually let me share my screen. And now it will, so that's good. Okay, everyone can see that okay? Great, thank you. Okay, so I'm going to talk a little bit about clinical practice guidelines and patient participation. A lot of this work was actually developed not from an ethics point of view, but mostly from the perspective of epistemology. But a number of the things that I talk about intersect with a lot of what bioethicists will work on as well. And so I'm happy to discuss this further. Hopefully, it speaks to the clinicians and non-clinicians in the room. I give this talk several times to clinicians, and it seems to resonate with them. I should also give a little bit of background here. A lot of this stuff is informed by my discussions with physicians in their practices, as opposed to just something that I read. I followed doctors around clinics for about 20 years. And so this is kind of a bit of what I learned just from my observations of their practices. Okay, so clinical practice guidelines, what are they? Well, they're systematically developed statements to assist practitioners and patient decisions about appropriate healthcare for special circumstances. This is the Institute of Medicine in the United States definition. But they're often used as a benchmark for quality of care. And this is very important because as benchmarks of quality of care, it actually has a very, very powerful influence on decision-making and on the content of clinical encounters. One of the big ways to develop clinical practice guidelines has been the GRADE framework, which was developed by the evidence-based medicine people, mostly at McMaster University. This is what they would call an evidence-based framework for developing clinical recommendations and clinical practice guidelines. And so I'm going to talk a little bit about what the GRADE framework, how it works, and how this actually influences the way we develop clinical practice guidelines, and then how that might actually influence clinical decisions. So what are clinical practice guidelines? They're general statements. They speak to populations of patients, but they also speak to individual patients and how you should handle care for individual patients. Thing is that care is delivered to populations, but at the level of individual patients. And so why do we need to focus on the individual patient? It's really important that when we have to consider the fact that a lot of the things that inform clinical practice are general statements about populations, but they do speak to individual patients when essentially the rubber hits the road, to use a saying that we have in North America. I'll get used to your sayings in that country when I visit. Anyhow, so why do we focus on the individual patient? Why does this matter? Individual patient contexts differ. Their circumstances, their values are not necessarily the same as populations. We're all different from each other. We all value different things. We all want different things. There's no guarantee that any individual patient is going to find meaningful whatever outcomes that a therapy is used to, the outcome that was used to define the benefit of a therapy. So clinical trials have outcomes. They demonstrate one therapy is better than another on the basis of that particular outcome, but there's no guarantee that you or me are going to find that outcome meaningful. The other thing is we can't assume that individuals will accept what is shown effective in trials. As I said, trials show average effects. Clinical practice guidelines are general statements. We can't necessarily assume that any individual is going to accept what those statements or what those trials show. This is also very important because health is not a transferable good. Winners can't compensate the losers, so to speak, and I'll show you what I mean by that. So let's consider a situation in which we have a choice here. One choice is we can flip a coin, for example. We can get 10 units or 0 units. If it comes up heads, we get 10 units. If it comes up tails, we get 0 units, right? Or we have another choice, which is a guarantee of 3 units. And I'll give you some tangible examples of what I mean by this. But if we were to figure out the value of these two choices for example, from a decision theory or a policymaker's perspective, the expected value of the first decision, this decision here, right? The coin flip is 5. And the expected value of the other decision is simply 3. Now, if we think about this in terms of things like our incomes, right? So suppose you went to your boss and you said, I'd like to get a pay raise, and your boss said, okay, that's fine. I'm going to flip a coin, and if it comes up heads, I'll give you $10,000, or it comes up tails, I'll give you $0, or you can just have a $3,000 pay raise. Well, the expected value of the coin flip is going to be higher than the expected value of the guaranteed dollar value. So if you're working on a law of large numbers, for example, let's say you're an employee in a large union, and this offer was given to everybody in the union, might suggest, well, everybody go for option one, because on average, it's going to come out to $5,000. What we could do is we could say every person who gets $10,000, that money is going to go into a common pool, and it's going to be split up evenly amongst all people in the union. If the union is large enough, everybody's going to get a better pay raise with the coin flip. Well, that's very different than if we're dealing with diseases, right? So if your physician offers you two ways of treating something, they can say, well, one option is we'll let you have surgery. It's a 50% chance that you will live 10 years and then you will die. Or there's a 50% chance that you will die during the surgery. Or the other option is we can give you this medical therapy and you'll live 3 years. Now, from a decision maker's point of view, right, from a public health point of view, or the point of view of somebody who's going to be dealing with services, with whole populations through a service, they would say the surgery is the better outcome, right? The surgery gives you an expected value of 5 years on average versus 3 years, right? But if you're an individual, you know, why would you accept the coin flip? You might die, right? And people can't compensate you the same way as if it was a pay raise. So now we're in a situation where we're forcing people, for example, because the expected value or the general statement is better with one thing over another, and we're going to force people into that decision. Well, how do we justify that? So the point I'm trying to make here is that being an individual or tailoring care to individuals really, really matters quite a bit. And when we develop statements in terms of how clinical practice ought to go, if we're basing those kinds of decisions off of average effects, or just, as I said, a general statement altogether, we might have a misalignment or a tension that actually comes into play when we deal with individual patients. And so what are some of the other issues that we have when we're dealing with this population data? It's not just a matter of this average effect, right? Clinical trials are statistical in nature, right? And this is insufficient for individuals because we don't know if the individual circumstances are going to reflect that of the people who were in the trial in the first place, right? And on top of that, we don't know if you're going to be one of the people, you in particular, is going to be a person who will benefit or not from the individual drug as it is, because some people do well and some people don't, right? And this has to be accounted for in whatever kinds of policies that we actually develop, for example, in the clinical practice guideline. So we also have the situation in which we might have, you know, our drug trial comes along, or you know, that's the basis for these clinical practice guidelines. And when we do our trial, we find, well, the people who are randomized to drug A, 80 of them lived and 20 of them died. And the people who are randomized to drug B, 20 of them lived and 80 of them died. And if anybody remembers their 2x2 tables here, that's an odds ratio of 4 in favor of drug A. The clinical trial is going to say, well, drug A is the way to go, right? But some people die on drug A and some people live on drug B. Well, what if we have a situation in which there's some other factor in play, right? We'll call it little a, and people who have whatever, maybe it's context or genetic factor little a, they live if they get the drug big A, and if you're a little b, you die if you get drug A, and vice versa. Well, unless we know the person's context or we know their genetic makeup, we would be, you know, there's a drug here that's saying, well, from a clinical trial or from a guideline, this is the better one because on a population, it's overwhelmingly beneficial. But for any individual, if, you know, for 20% of the population who actually hold this little B context or gene or whatever it is, we're actually hurting them. And so the good thing is, clinicians are pretty good at trying to tease these kinds of contexts or differences out. But then when we end up in situations where there's a quality metric or a correct way of doing things, it might disincentivize them to actually try to find these little contexts and figure out what actually is better for some patients than others. Now, this whole idea of the individual, right, and why we should not just be fully focused on these general statements is actually recognized in some of the classic literature around evidence-based medicine and around things like variations in medical practice. So the first quote here by Dave Sackett, many people recognize as being one of the key members in the evidence-based medicine movement. Some would consider him to be the grandfather of it. He said, evidence-based medicine is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. So it was never about populations. It was always about individuals. Brian Haynes, contemporary with Dave Sackett at McMaster, he said in BMJ in 2002, clinicians must apply their expertise to assess the patient's problem and must also incorporate the research evidence and the patient's preferences or values before making a management recommendation. So again, it's not just about applying a general rule, it's also about tailoring care. And then John Wenberg, who did the classic work and variations in medical practice going back to the 1970s, said treating patients according to their preferences and not giving them treatments they do not want requires a clinical environment that supports shared decision-making and encourages the active engagement of patients in the choice of treatment. So what we see here is clinical practice, even amongst the people who are pushing an agenda of clinical trials and evidence-based medicine, are very, very keen on this idea that care needs to be tailored, that patient perspectives are important, and that the individual matters. We see this in the evolution of the evidence-based medicine movement, which then I would say has now led to the GRADE framework and clinical practice guidelines, which I'll get to in a second. And we see very early on patient preferences was part of the decision-making process, along with the research evidence and clinical expertise. And moving into the early 2000s, we see clinical expertise as kind of just this overarching feature, but now you have patient preferences and actions. And then as we move into 2005, we see patient preferences and actions as well. Other things, healthcare resources, new factors are starting to play a role, but the patient piece, the preference piece has always been part of it. Okay, so hopefully I've convinced you that the individual matters and that even people who operate in places like evidence-based medicine and clinical trialists also agree with that concept as well. I'm going to turn their attention a little bit to the GRADE framework and what it is and how it came about. So this is actually, I don't know if anyone here is familiar with the GRADE framework, but this is I guess the brainchild of the evidence-based medicine movement. And it was the next step in trying to figure out how to take the best evidence from our studies and translate those into clinical practice. So what is it? So the GRADE framework is a framework for how to judge and weigh evidence in the healthcare context. It tells us what confidence we should have in research findings for specified decisions. It also tells us what else we should consider when we're actually coming up with recommendations. It's been said to guide evidence-based decision-making. It outlines a framework and a process for making recommendations, and it provides meaning of those recommendations for clinical practice. And this is going to be a very, very important part of my talk, is that meaning for clinical practice that is actually implied by these general statements. So Gord Guyot, who's the person who is credited with the first papers in coining the term evidence-based medicine, also a key developer of the GRADE framework, said in 2007 that GRADE may facilitate the evolution towards a world in which expert recommendations for frontline clinicians uniformly adhere to the principles of evidence management and guideline development that flow from the intellectual movement we call evidence-based medicine. So what we're hoping to see with the grade framework is an alignment between the principles of evidence-based medicine and also the spirit of evidence-based medicine, and also incorporating the individual's preferences and the individual context into care. That would be the assumption. GRADE is a very, very important framework, as I mentioned. It's been adopted by 110 organizations in 19 countries. 19 countries actually have GRADE centers. You can look at this list here. You probably recognize a lot of the logos there, right off the top in the top left corner, World Health Organization. And there's a number of journals that actually also adopt the GRADE framework in terms of it being considered what they believe to be the best way to do these things. So this is a highly influential model for recommendations, which then becomes a highly influential model for clinical practice if everybody is practicing evidence-based medicine, or so would be the ideal situation. So what are the core activities in GRADE? Well, the first thing is assessing the quality of evidence, and it uses something what I call a modified evidence-based medicine hierarchy. I suspect everyone here has seen evidence hierarchies, right? Randomized control trials on top, clinical judgment or mechanistic reasoning on the bottom. The more systematic the collection of the evidence, the more rigorous the way the evidence is collected, the more confidence we can have in the effect sizes or the effect estimates that come from it, and the higher the evidence quality is to be considered. And this is the modified framework. So as I said, randomized control trials start off as high levels of evidence, observational studies as low levels of evidence. And there's a way to upgrade and downgrade that quality on the basis of different kinds of bias. Or other factors like dose responses or effect sizes, large effect sizes, which will allow you to upgrade or downgrade the quality of evidence. So the really important point here is that methodological rigor, is actually more than just did you randomize people or not randomize people, and that methodological rigor is very, very important in the development of clinical recommendations. Okay. The other activity, and this is the one I'm going to focus most of the attention on here, is the recommendation for practice, right? So there's considerations beyond just the effect estimate. And so how do we actually articulate these recommendations? Well, we have our quality of evidence, which is supposed to lead to a recommendation of practice, but there's a recognition that values and preferences, equity, economic considerations, various other things are going to actually play a role in mediating that recommendation for practice once we have evidence in our hands, right? And then from here, the decision through the GRADE framework is you make a recommendation, it is a weak recommendation or it is a strong recommendation. There's certain meanings to what weak and strong actually have for the patient and how you ought to encounter the patient. So we have several models of decision-making that actually are implied by the GRADE framework, and I'm sure everyone here is aware of some of these: shared decision-making, paternalism, there's anything in between. So as I said, the GRADE framework actually hints at how these decisions ought to be made on the basis of the recommendations. And I'm going to show you it's on the basis of whether or not you consider something to be a weak recommendation versus a strong recommendation. The framework also includes a process for integrating the best evidence with other considerations. This is an integration problem that I've actually spoken about in the literature. I'm not going to talk too much about that here. And it also tells you what the clinician should do with the recommendation. And this actually has very, very important implications on the clinical encounter itself. So just a quick reminder for anybody who hasn't thought about this for a while: different models of decision-making. On the one end of the continuum, you have paternalism. Right? What is paternalism? Well, information is shared one way from the physician or the clinician to the patient. What is actually shared is medical information, and the amount is the minimum required legally for a person to actually be able to make the correct or consent to a procedure. There's some deliberation that happens from the physician's perspective, and then a decision. The physician actually makes a decision and then recommends it to the patient. That's the purest of paternalistic models. We have a shared model, which is the one that is much more emphasized these days, right? Where there's two-way information sharing, and all the information that's relevant amongst all the members of the encounter. And then you have the informed decision, which again is you just give the patient all this information, and then the patient deliberates and the patient makes the decision. And there's anything in between. So how do these different models fit into the grade framework? Well, when you have a strong recommendation in the grade framework, from the patient's perspective, strong means most people in your situation would want the recommended course of action, and only a small proportion would not. Request discussion if the intervention is not offered. So that's what it's supposed to mean for a patient. From the clinician's perspective, it is most patients should receive the recommended course of action. Clinicians can apply strong recommendations to all or almost all patients in all or almost all circumstances without thorough or even cursory review of the underlying evidence and without detailed discussion with the patient. That so to give it a little bit more, reflects the extent to which we can be confident that the desirable effects of an intervention outweigh the undesirable effects. For clinicians, a strong recommendation means just do it. Spending constrained time individualizing care is unlikely to be productive. That sounds an awful lot like paternalism to me, right? So information exchange is primarily from clinician to patient, right? Individual patient values and preferences are assumed from the population or panel impression. Review of the evidence and detailed discussion with the patient is de-emphasized. Decision-making is primarily clinician, just do it. Spending time individualizing care, not considered productive. That sounds awfully paternalistic to me. I mean, this is going to be very important because you're going to see how do strong recommendations come about. Weak recommendations, on the other hand, most people from the patient's perspective, most people in your situation would want a recommended course of action, but many would not. And from the clinician's perspective, they should recognize that different choices will be appropriate for different patients and that you must help each patient to arrive at a management decision consistent with her or his values and preferences. A weak recommendation means that optimal management will involve considering the patient's particular circumstances and engaging in shared decision-making. Now, I apologize for all of these quotes, but you have to actually see the quotes, right? It's very, very explicit in these quotes. So what you see here is information exchange in a weak recommendation is two ways, right? Individual patients provide their values and preferences. Clinicians provide the medical information. Decision-making encourages patient engagement and to consider the individual circumstances. So it's actually explicitly said shared decision-making. Now, the whole theory around philosophy around shared decision-making does not actually partition off these are circumstances when it's okay and these are ones when it's not. And yet the grade framework says, well, there are actually specific situations in which shared decision-making is encouraged and other situations where it's encouraged to really avoid getting into too much detail, save your time, move on, make decisions. So the question then becomes, why should the model of decision-making be based on the strength of a recommendation, right? Especially when we know that not all patients are going to accept what is being recommended. Right? But the patient perspective is a consideration in the determination of the strength of guidelines. That's what they'll say. They'll say, well, no, but we understand this. That's incorporated into how we come up with a strong recommendation, right? We call it values and preferences. But when you look at the empirical evidence around how the strength of a recommendation is decided, strong recommendations are almost exclusively driven by the certainty of evidence. Now, the next thing becomes, well, how do they even incorporate values and preferences in the first place? Well, here's a definition of how they do it, or this is a definition of what they mean by values and preferences in the first place. This is in the grade literature as well. Values and preferences is an overarching term that includes patients' perspectives, beliefs and expectations, and goals for health and life. More precisely, they refer to the processes that individuals use in considering the potential benefits, harms, costs, limitations, and inconvenience of management options to one another, right? So the first part of this definition appears to talk about values. The second refers to a process. Doesn't actually tell you what we mean by a preference. A preference can be revealed by a process, but a process is not a preference. So you have these things that are values, which are principles or standards of behavior, and you have these things called preferences, which is a greater liking of one alternative over others. And what they talk about is this thing called values and preferences, which seems to be this holistic concept, which doesn't actually speak to these two things. It speaks to one of these, but not both, right? So how are the values and preferences linked in their definition? And the most important thing is, how are they even measured, right? So even the EBM people have concerns with this definition, right? So they said there are diverse opinions and confusion about defining and including patient values and preferences in guideline development process, right? The only thing is that what they do when they're in this literature is they conflate values and preferences with the importance placed on health outcomes. Actually, in their definition, they even say the importance placed on health outcomes. The definition of and strategies for determining values and preferences are still under debate. This is in their own literature. And yet, they then offered definitions like this one here, after they've already admitted that there are these concerns. So this is one from Zhang et al., again, from the EBM literature, from the grade literature and the EBM literature. The relative importance of outcomes or health states of interest. That's what values and preferences. It's someone's relative importance of outcomes or health states of interest. So similarly, in health economics, preference is a general term that includes health utilities elicited under uncertainty, which are results from a standard gamble, as well as the values elicited under certainty with time trade-off using or a visual analog scale. The preferences for or against an intervention is conceptually equivalent to the importance placed on outcomes that follow from the decision to undergo an intervention. So what they're saying is, well, there's a technical definition of these values and preferences, and you can find these things from using tools like standard gambles or time trade-offs or visual analog scales. Well, the thing is these are things you do at a population level. These are not things that you do for an individual, right? So again, right, it defines patient values and preferences as relative importance to an outcome, which is actually only part of the problem. I'll talk about the other one. The other one is about it being about typical patients. So focus on outcomes alone is problematic because preferences for an outcome does not necessarily predict a choice, right? Outcomes from care are not guaranteed. So a patient can't choose an outcome. They never choose outcomes when they're making decisions about care, right? They're choosing therapies and they're hoping for outcomes. A specified therapy has many outcomes, and rarely is one therapy dominant on all of those outcomes. There's lots of effects. Some of them are positive effects and negative effects. Some of these effects have implied trade-offs, but not everybody is going to get the side effect or the main effect. They can't say, well, this drug is good for my heart, but I'm going to lose my hair. There's no guarantee that either of those things are going to happen, right? So moving from a preference for outcome to a preference for therapy is not a trivial task. So how do they do these things at the development of a recommendation in the guideline framework? Well, they say, well, ideally to inform estimates of the typical patient values and preferences, guideline panels will conduct or identify systematic reviews of relevant studies of patient values and preferences. Given the paucity of empirical examinations of patients' values and preferences, however, well-resourced guideline panels will usually complement such studies with consultation with individual patients and patient groups. And again, we're seeing this emphasis of the general, right? Patient decisions are made for individuals. So this whole idea of this typical patient, well, what do you even mean by a typical patient? Who's the typical patient? Right? There's no expectation that individual patient values and preferences or effectiveness or anything is going to reflect that of the population. And in grade, the research evidence and panel interpretation or the perception is what determines what the patient will want, not the individual patient in the clinical encounter. The guideline panel says we collect this information at a general level, and then we're going to make a recommendation on what we think patients are going to want on the basis of what we expect they're telling us. My whole claim is, well, why don't you just ask the patient? She's right there in front of you in the clinical encounter. So why have recommendations? Why even build into recommendations anything about how to encounter or engage the patient? Right? It's paternalism in through the back door. So just to sum it up here, patient values and preferences are assumed from populations or by the panel, and these might not align with that of the patient or in the clinical encounter, and it's not exactly clear how they're measured in the first place. And these things will load on to strong versus weak recommendations, which seem to be usually based on the certainty of the effect estimate, which is based on the strength of the clinical trials. And my whole claim here is, well, why should patients be engaged differently as a function of the recommendation of the strength of the recommendation? It's not clear to me why that should matter at all. So that's where I'm going to leave it. And I'm sorry I went through that quickly, but I knew we'd have lots of time for conversation. And this is a philosophy group, so I expect you have lots to say. So happy to take any questions or hear your comments or concerns on this.
Thank you, Matthew. So in the room, if you've got a question, just raise your hand, and online, I'm going to keep a good eye on the chat and also the raise hand function. So is anyone, I'll just see if anyone online wants to put their hand up or about in here. Mike, what do you want to go first? Oh, sorry.
Oh, sorry.
Go ahead. Okay.
Thank you. That was an excellent talk. I'm a bit worried about the comparison with going to my car mechanic, in that I go to the car mechanic, and one thing I want him to tell me is what will turn out best. What's the proper way to fix the car? Because to get it working properly again. And that's not only an analogy, but also in my own clinical practice as a brain surgeon, many patients used to say, well, heck, you're the brain surgeon. You tell me what's the best choice here. Because, heck, I haven't seen this before. And in a sense, we are hypocritically obliged to give that information as clearly as we can, even though I know many brain surgeons, in fact, go for something highly unlikely, like total cure, to be the gold standard they should aim for, when the gold standard is actually patient at the end of the day realizes or reflects that the best was done that could be expected.
Yeah. So, so first off, I would like to, I guess, I don't mean to suggest that that physicians should not offer recommendations by any means, and I don't think that that's what you're suggesting either. I'll tell you a very quick story. I broke my jaw when I was living in New York, and I developed something called a resorption, which a lot of people don't know about, but you're medical people, so you probably have heard of it. I went to my dentist. My dentist sent me to a specialist, and the specialist said, well, there's 3 ways we can fix it. We can just pull the tooth. We can just sit on it for a while and see what happens, and then perhaps we have to pull the tooth, or we can do a root canal, and we can cut your gums away, and we can go in the side, and we can fill it with silver, and so on and so on and so on. And he said, which would you like? And my response to him was, I don't know. Right? I don't know which I'd like. And so my first question to him was, you've seen people with this kind of situation. what would you recommend? And he was reluctant to recommend anything to me. So I went to a different doctor. And I found someone who was willing to recommend something. And I mean, and so, you know, paternalism is not necessarily a bad thing for a clinical encounter. But I think what's really important is to recognize, you know, everybody in the room has to be willing to engage that way. So patients have to be willing to say, Doc, you tell me what to do. But physicians also have to be people who are willing to take on that responsibility. And not everybody wants to take that responsibility for all decisions. And so I'm not suggesting that shared decision-making is the model. I just think that shared decision-making shouldn't be implied by the strength of a recommendation. And in terms of your analogy with a car mechanic, I mean, it's really interesting. I mean, the one thing that a car mechanic can do is guarantee the work. I mean, hopefully you don't drive off and get into an accident because their work wasn't guaranteed, but save the fact that you survive the drive home. You can bring the car back and they can repair it again. Unfortunately, as with health not being transferable, you can't offer guarantees. So that makes it a little bit more difficult. Now, I don't know if I answered your question, but just the things that you were saying kind of prompted in my mind some of those thoughts as well. So.
Thank you. So Mike had his hand up, and then I'm going to go to the two online. So you're going to go first, then we'll go to Ben, and then John McMillan.
Thanks very much. Very interesting and interesting talk and well-made argument. Thanks, Matt. So I think you certainly convinced me that there's problems here with the guidelines. It seems to me that I can see why you make guidelines, because people don't have a lot of time in a clinical encounter to go through this discussion every time. And you could get ad hoc sort of anecdotal kind of guidelines that people develop, you know, either in practices or in their particular clinical practice. So you're going to get a really various sort of a thing, because people need heuristics to try and reduce the amount of time in the clinical encounter. So I'm just wondering if that's true. That seems a reason in favor of guidelines, and I wonder, not a all things considered reason to do them, but I just wonder if that is a reason to try and look to improving the guidelines in some way, or the guideline development process or something like that, to address the issues that you raise, like, for example, perhaps grading evidence on some of the features of evidence as a whole, perhaps, that you were talking about. If it kills these people but not those people, then that could be a reason to somehow factor that into the guideline process, you know, the guideline development process or something like that. So I suppose, just long story short, is there a way to just improve the grade system to address your concern?
Yeah. I mean, I think that the simple solution to the grade system is, one, put more emphasis on the eliciting values and preferences at the stage of the development of the recommendation in the first place. And then two, disentangle the strength of a recommendation with the way in which they're recommending you encounter patients in the first place. And it could be quite that simple. I mean, guidelines are an important tool. Lots of people love guidelines, and they love them for different reasons, right? Healthcare managers love guidelines because it creates a system of accountability for them, or a way to actually plan. Physicians, I did a lot of empirical research around how physicians use guidelines, and physicians love guidelines. When I did all my work on why physicians deviate from guidelines, they always start with, I'd give them scenarios and they'd say, well, you know, the guidelines say I should do this. And then they would start to deviate, and they tell you a story as to why they're deviating. And those stories were often very reasonable, right? Well, this patient actually has these other concerns. So it's a nice way to kind of organize your care. And it's very important that way. Where guidelines become problematic when they're developed in this way is when you create remuneration strategies that are closely aligned with the extent to which clinicians are following the guidelines, which might create incentive structures that incentivize care that is problematic for some patients. And so we have to be very aware of those kinds of things as well. So I think if we just recognize the general gap that is here, then we actually have an opportunity to start addressing the development of guidelines in better ways. But I'm by no means suggesting we just throw guidelines away and let clinicians do whatever they want, because clinicians find guidelines valuable, right? And they are useful. So I'm not going to suggest anything different.
So Ben Gray, you have your hand up online.
Kia ora, Matt. So my background is a general practitioner, and I've been very interested in this particular area, and would particularly recommend the work of James McCormack in Vancouver, who's written some really interesting things about how little values and preferences even appear in any of the guidelines, and who has a very strong position, which is that guidelines should be guidelines of when to discuss with the patient, not when to do something. So I think there is a whole load of work as to what we think of guidelines as being, because they're only evidence of an element of what the person might value. And even before you get to, I mean, someone with diabetes, they might not want to talk about that. They might want to talk about the fact they haven't got anywhere to live. And so applying guidelines to them is meaningless, because that's not actually what they've come to see you for. So that's the first train of thought. The other train of thought is just the issue of relationship. And just to extend Grant's analogy with the motor mechanic, I had the same motor mechanic for 30 years here in Wellington. I knew him very well. He knew me. I would just say, do it. Because I knew he knew where I sat on price points. I didn't want the best, fanciest tires, but I wanted something that was safe. I want, that he understood my values and preferences, and I trusted him to know them, and therefore didn't want to talk about which tire he got or whether he should replace the disc brake now or later. I was saying, no, this is your decision. And it was a model of relationship and trust, as opposed to a model of informed decision-making and patient autonomy. And I think that there's a huge variation culturally of some groups of people for whom relationship and trust is actually how they operate. And that I've certainly had patients come to me and say, well, they say, well, what do you think, doctor, if I ever give them a choice? And then if I say something, they say, well, I'll do that then. So I think the ways in which people make decisions is highly variable. And so I think that needs to go into the whole mix as to how we manage it. And then in terms of following up on therapy, it doesn't matter how good a recommendation is. If I haven't got the patient's buy-in to do it, they won't take the pills when they go home. So the relationship is actually fundamental, even if it's a really, really valuable, effective recommendation.
Yeah, and I think those are all excellent thoughts, and I share a lot of that. Your position on these things. When I got into the guideline issue, I mean, the big problem for me in all of this was I was following cardiologists around. I mean, these were the big clinical trialists in the world in interventional cardiology. I was following them around, and I would look at things, because one of my jobs in the hospital was, well, why are people deviating from the best practices, and what are the clinical trials saying? And I would always sit down with the physicians. I'd say, well, why did you do this? And they'd say, well, these are the reasons, and they'd tell you this different story, and they would always speak to the relational aspects between them and the patient. And there's this trend, and again, it's not a trend that's being driven by clinicians or people who actually engage patients. It's being driven by people who have co-opted evidence-based medicine and clinical practice guidelines for purposes of what is almost seems to be exclusively controlling budgets, right? It's always about reducing the budget, right? This is the cheaper way that we can practice. Incidentally, before I work in emergency medicine now, that's like I'm not a clinician, but that's my academic post within the Department of Medicine. I got that post because years ago, when I got into guideline care experiments, I started off with general practitioners, and I said, well, here's a scenario, which drug would you give? Which therapy would you approach? And they would always say, well, I don't know. Yeah, I need to know more about the patient. And they'd start telling you stories. Well, I know patients who would accept these things, and I know patients who wouldn't accept these things. And so they would say things like, well, I might start with X, And then we'll try it for a few weeks, and then we'll come back around to it. And if it's a different patient, I might start with Y, and then we'll eventually get to X. And so it was very difficult to do experiments with them because they wouldn't to do these experiments, you would have to get very specific, here's my decision. It was all, but their whole decision was based on a relationship. So I moved to emergency medicine and did the experiment where they don't develop relationships with patients the same way because they may never see the patient again. It's often a stabilize the patient and then refer them to the specialist or back to their general practitioner. And so they really loved guidelines because guidelines allowed them to kind of develop policies for practice, and especially when they're dealing with things where they might not see the same kind of patient for another 6 months. My general practitioner, I love my general practitioner. Why? I knew her for a decade before she became my doctor. My wife didn't have the same experience with her because my wife wants something different in her practitioner than I do. Right? Mine, we have discussions of the evidence. She knows which specialist to refer me to because she knows my personality. And it's a great relationship. So I agree with you. These things matter. This whole idea, though, that I see care going down this road of algorithms that are generated using these tools that make them scientific or objective in some way. And then, of course, the next cost-cutting measure in places in America, I'm not sure what it's like in your country, is let's take the most expensive link out of the chain and replace them with an algorithm, right? Well, that's going to be a problem, right? At least unless you find ways to integrate some of the things you're suggesting into the process. And right now, we're nowhere close to that. So I worry. I see a doctor because it's a person, right? And that person is empathetic or develops relationships with people. I think those things matter. These are not objective decisions.
So Matthew, we just have about 7 minutes, and I think at least 2 questions. So John McMillan and then Lindley here, and I'll see if there's another one after that. Go ahead, John.
Hi, Matthew. Thanks. Really enjoyed that talk. In publicly funded healthcare systems, we rely upon weighted preferences for qualities and things like that. So they're kind of all over the place. But I'm perhaps like you, nervous about using data about or treating views about values or preferences as being data in some kind. And one of the reasons is because it's there are cases where people will survey people's what you think about this, and then that's taken as somehow a statement of value. So it kind of undermines the nature of value, some of this research. So I've got that sort of right. But when you were talking about the difference between the two medications, I was thinking about this slide I saw a pharmacologist put up years ago for and so it was plotting the reaction to a particular medication in a population, and even with the clinical guideline for something that's kind of the best thing that you could take for this if you're part of this population, there's always this question about whether you're going to be lucky or unlucky, and there's a discussion that Chris Jackson uses that so Simon and I teach with when he's talking about oncology, he'll talk about the clinical evidence and the guidelines and frame them in terms of how things have gone like this in the past, if it goes bad and if it goes well. So framing the evidence-based information in that way. So I was thinking about uncertainty in connection with communicating about clinical guidelines, and maybe values and preferences kind of trip us up a bit, and it's that. What degree of uncertainty are you comfortable with?
Yeah, I mean, I find sometimes that the values and preferences were like what Wenberg would call, preference-sensitive care, or often these things that were invoked when there was more uncertainty around the effect size, or there's more variability in the kinds of effects that you're going to get amongst patients. I've always challenged that notion. I think that all decision-making, being a philosopher as well as an epidemiologist, I think all decision-making is under uncertainty. You're dealing with complex systems. So I worry about this this belief that might be generated, that the stronger people consider the guideline to be, the impression we're giving people is that this uncertainty is actually somehow magically disappearing. And you know, I understand the struggle that clinicians have. They say, well, I have patients who want answers. But there's lots of ways that you can give a patient an answer, right? So there's two ways you can say. You can say, well, the guidelines say you should do this, and so this is what I'm going to recommend. The other thing you can say is clinical trial. I don't know what's going to work best for you. We have clinical trials that show this drug is, generally speaking, people get good effects with it. My clinical practice and my experience with patients who are like you show something very similar. I suggest we start with this and we'll see how things go. And we'll come back and we'll change course if it's not working, but I'm here to help you. Now, the second situation, I gave you lots of uncertainty in that. But when someone speaks to me that way, I feel much better. And maybe that's unique to me, I'm not sure. But there are ways to discuss uncertainty that also reassure. And I think that that's something that is kind of missing in all of this literature. It's in the literature, it's not in this literature of this kind of discussion.
Thank you, Lindley.
Thanks. That was really, really interesting, and I really enjoyed that. I'm not terribly sure how useful this comment is, but I was thinking more about, in the absence of guidelines, and often the clinician will go away and speak to a multidisciplinary team meeting and then come back to the patient with what appears to be a kind of a guideline as based on the multidisciplinary team meeting and present it to the patient. I mean, I've had experience personally with this kind of approach. So there's no guidelines, but they go away and discuss, and they come to the patient with a very strong recommendation based on the multidisciplinary team meeting, which isn't terribly, there's not a lot of scope for patient autonomy, but it's very paternalistic. I just wonder whether you could actually think about that as well.
Yeah, I mean, we also in our healthcare, we have this illusion of choice in the first place, right? Yeah. I mean, you can choose to take it or not take it, and sometimes it's this therapy, that therapy, or nothing. So many decisions are actually made at much higher levels. Guidelines is one piece. Another place where these things are made in terms of what your local governments are going to approve, what people are going to pay for in the first place, how people are insured. And by the time it gets to the patient, we say, well, there's this choice that you have, and well, maybe there isn't. And so it might ultimately be very paternalistic at its very core. And so my points that I'm making here may be moot, because this is just another piece of what is ultimately a decision that is outside the hands of anybody, right? I mean, the clinicians in the room here, I mean, can you honestly say that in all the circumstances that you're in, even if the choice was yours, do you really have a choice, right? Often you don't. Often you're doing the best you can with what you have, and you don't have much. And so it's nice to have communities of practice where you have people that you can talk to, and those communities are getting larger and larger now, and the tools that are being developed to help inform clinicians are getting better and better. But I mean, let's be honest, often you're at a loss, right? And so yeah, you're only as good as your community, I guess, at that point. So yeah, I think your point is fascinating, and it speaks to the bigger issue of clinical practice.
So thank you very much, Matthew. Thank you from everyone here in the room and all of the people online for this really interesting seminar. Our next seminar, which is at the same time on Monday next week, on the 15th of April, is Michael Phillips from the University of Canterbury, who will be speaking on the moral consequences of perceiving animal minds, and this you can attend in person or online. But I just want to now thank Matthew for his wonderful talk. Thank you very much.
Thank you so much. I really enjoyed this, and I hope to come down and visit in person to what I believe is the most beautiful island in the world. I live on the North Island half the year. I love the South.
Oh yeah, come on down. We'll see you soon.
We'll do that.
Okay.
Thank you.
Bye.